Hey everyone, welcome to this explainer. Today, we are unpacking the RRT code stroke tool. If you've ever worked on a rapid response team, you already know that a code stroke is a massive adrenaline rush. It's a high-stress, high-speed clinical event filled with really high-stakes decisions. To navigate that kind of chaos, you literally need a brass and gears blueprint, a system that ensures every single member of your team operates with total clockwork precision. And honestly, that is exactly what this tool is designed to do. So here's our quick agenda for today. We're going to cover the high-stakes code stroke, then ticking clocks and time goals. After that, we'll dive into the critical 7, navigating to targeted therapies, and finally, blueprints for your education and documentation. Let's get right into it. Section 1, the high-stakes code stroke, calibrating the team. Okay, right off the bat, when a code is activated and you reach out to the neurology attending, you absolutely must anchor your communication. You want to always start by providing the patient's name, age, and location. But to do this effectively, the RRT tool card has to be treated like your master navigator's instrument. You should always carry this card on you at the ready. A code stroke is just way too fast and the stakes are way too high to just rely on memory alone. Keeping this tool right in your pocket ensures you have your operational checklist right there, allowing you and your team to function as a seamless unit under immense pressure. Moving on to Section 2, ticking clocks and time goals, beating the timer. In stroke care, time is essentially our ultimate enemy. Because of that, the tool requires you to meticulously document the exact flow of the code. You need to log the time from the very first call. If that BFAST assessment is positive, you log exactly when the code stroke is activated. You've got to track the first and second pages to neurology, when they actually call back, when the patient arrives at the CT suite. Tracking these specific metrics is what keeps the engine of this entire protocol running right on schedule. And you might be wondering, why are we tracking time so obsessively? Well, it all comes down to this number right here, 45. Our aggressive goal is to administer IV tenecteplase, or TNK, as safely and quickly as possible, specifically under 45 minutes from the onset of symptoms. Because in a stroke, every minute saved is literally brain tissue saved. But what if the patient needs to bypass that and go straight to the angio suite? In that case, our target shifts to 90. For endovascular therapy, the pressure is really on to reach a door-to-treatment time of 90 minutes or less from symptom onset. Hitting these precise marks? Yeah, that requires absolute teamwork and focus. Section 3, the critical 7. Items 0 through 6. This is the data fueling our decisions. Before we can administer any kind of therapy, we have to establish LKOS. That stands for last known and usual state of health. Defining this is absolutely essential because it acts as the master anchor point. It literally starts the ticking clock for every single decision that follows. Was it less than 4.5 hours ago? Less than 9? 24? Or, is this a wake-up stroke? You must lock down this anchor time. So here is the exact checklist, items 0 through 6. You must gather these and have them ready to communicate clearly to the neurology attending. You start with acute signs, making sure to only score the new stroke symptoms, like checking if the eyes are force deviated. Then establish your LQSH timeframe. Next, calculate the NIH stroke scale out of 42. Figure out their pre-admission modified ranking score, or MRS, then grab vitals, check blood sugar, and finally, determine their anticoagulant use and coagulopathy status. While you're gathering all that data, you also have to stabilize the physical gauges of your patient. Systolic blood pressure needs to be tightly managed between 140 and 180. Glycemia should sit between 60 and 400. And at the exact same time, you are hunting for coagulopathy risks. Is their INR 1.7 or higher? What was the exact time of their last anticoagulant dose? Every single piece of this data dictates the next turn of the gear. Section 4, navigating to targeted therapies, opening the valves. Once we have our data, we go down one of two high-speed pipelines. So let's look at the divergent paths. For IVTPN, the goal is generally to administer it within a strict 4.5-hour window from symptom onset, although the tool does remind us this can be extended up to 9 hours in very select cases. Now for endovascular therapy, we have a wider window. It can be considered for patients up to 24 hours from the onset of symptoms. And this is huge because it crucially includes certain wake-up strokes that meet the therapy criteria. But to actually unlock that endovascular route, specific criteria from your critical 7 must be met. Usually the patient needs an NIHS score of 6 or greater, which indicates a disabling stroke. They also need a baseline pre-admission MRS of 3 or less, meaning they had a reasonable level of independence before this happened. You're also looking to confirm a large artery occlusion on the CT angiogram. If all these align, you rush them to the angio suite. Finally, Section 5, blueprints, education and documentation. Even the best clinical teams need to consult the schematics, which is why this tool is packed with supplemental education. Right on the physical tool, there are embedded QR codes. And listen, these aren't just for when a live code is happening. They are incredible for managing high-stress clinical drills. By scanning these during downtime, your team can rehearse the BFAST assessment or watch the How to Run a Code Stroke video. Rehearsing this protocol over and over improves muscle memory, which will massively increase your team's speed when a real code drops. The training continues with 2 more integrated QR codes. These give you immediate, succinct video refreshers for accurately scoring the NIHSS out of 42 and evaluating that pre-admission MRS. when you're running a fast-paced drill, or frankly, if you just need a quick reminder during a shift of how to score a weird neurological deficit, these digital blueprints are right there at your fingertips. At the very end of the line, after the immediate crisis is managed and your patient is safely transferred, you have one final duty: complete the operational log. Add a short, clarifying narrative in the RRT medical record note. Documenting the exact flow of each process not only completes the patient's record, but it gives you the data you need to debrief, adapt your clinical drills, and speed up your response for next time. So the ultimate question is this: will you carry your RRT tool card at the ready? This framework is absolutely incredible, but it only works if it's actually in your hands. Make sure you are always prepared to be the driving force your rapid response team needs to master the clockwork precision of stroke care. Thanks for joining me on this explainer, and stay focused out there.